Welcome to my presentation on keys to good documentation. This is Rory and I welcome you to this presentation. We're going to talk about strategies to help you improve documentation. And one of the first things that's just so vitally important for you to realize is that documentation is a skill. It is a professional skill, just like starting an IV, placing a patient on a backboard, splinting, intubation. It's a skill. And so it's very, very important. And how important is it? Well, 28% of your runtime can be spent on reports. And it's just as important as other skills. And I'm going to tell you why later, but I'm going to tell you some things that can help you in your strategies for good documentation. Because documentation can make you look professional or it can make you look unprofessional. It's up to you. You decide. So strategy number one is you've got to make time for documentation. Now, I realize patient is still your number one priority. And most of the time, most of us are doing our documentation after the call. We may write down a few points or things to help us remember some things that we did or the times that we did them later. But at the time of the call, we're taking care of a patient, and that's as it should be. The patient is still the number one priority. You should document as soon as possible. Don't put it aside. Don't wait for hours after the call, especially if you work a service where you run a lot of calls. Cheat sheets are good tools. Early in my career, I used cheat sheets. It was just a sheet that I took to write down different things that I wanted to make sure I included in my documentation later. Sometimes they were just quick little jots of a note, bullet point to help me remember something later on when I did sit down to document. Find a method and use a method that works for you, and we'll talk about that a little more later. Before you begin to document, plan. Have a plan before you start to write. We're going to talk about one type of plan. We're not going to talk about the other two. So you've got to decide what to write, especially in your narrative. Now, in most run reports, whether they're paper or electronic, there are things that you just have to put down. You have to put down vital signs. You have to put times of the calls, the addresses, patient's name, date of birth, phone numbers, and things like that. But what we're talking about here really is the narrative portion. And so get a system and stick with that system. And I'm going to talk to you a couple of ways of trying to get a system. And there are three big main systems out there. SOAP, which that's the one we're going to concentrate in this presentation. There's also CHART, and then there's also NAP. And NAP stands for Narrative Assessment and Plan. I don't remember exactly what CHART stands for. We can look that up. But we're going to talk about SOAP now. We're going to go in to talk about SOAP. And the S stands for subjective. Things that are subjective they're not always cut and dry, okay? It's meaning it's subjective by it's what the patient, family, or bystanders say. It can be an opinion. Whenever possible, use the patient's own words. And by the way, if you use the patient's own words, put them in quotation marks. If you quote anybody, put quotation marks. Now, it's also okay to paraphrase what someone said. If you do that, you don't need to use quotation marks. But that's the subjective part. For example, you get on a call and family member says, Mom just started acting really strange and slurring her words, and she became weak on one side. And these types of things are subjective. They're what they're saying. And then when you look at the patient, then you're going to see some things that hopefully you put together the subjective and the objective that we're going to talk about next. And those are parts of your patient assessment that are going to help you come to a conclusion as to what's wrong. And so when you think of the word objective, think of O as observe. It's what you observe or what you can see. Now, in the example I just gave you, the family member said that Mom was slurring words and was weak on one side. And so let's say you use the Cincinnati stroke scale, and you see that when you ask the patient to smile, one side of the smile doesn't go up. The face is drooping. You ask them to grasp your hand, squeeze your hands, and one side is weaker than the other. That's something that you observe. That's something that you see. And so that's part of that patient assessment. It includes vital signs not documented elsewhere. And again, let me remind you that we're talking about the narrative, and I'm a big believer in not duplicating what you put down elsewhere. So if you didn't put vitals, if there wasn't an area or you ran out of room on sets of vitals in the place for vitals, then of course you certainly can put them here in the objective. And I'm not against you putting all the vitals in here and repeating, but I just don't think it's necessary unless the company or the provider you work for dictates that. And so you have to go by the protocols where you work and the policies and procedures where you work on how you document certain things. And as I said about the subjective, the objective portion is also part of your actual patient assessment. You're assessing of the patient. And so in SOAP, assessment actually means your assessment of your assessment. Now, does that confuse you? Let's put it another way. It's your field diagnosis, your pre-hospital diagnosis. Or in other words, what do you think is going on by your findings? By your subjective and objective findings, what do you think is going on? It's your assessment of these previous findings. It's not the patient assessment, if you understand what I mean. And it's often the same as the chief complaint. Now, let's take the same example I was using. Our assessment would be that the patient is possibly having a stroke, a CVA, or a TIA. Though we're not sure, and though we're not doctors and we're not to diagnose, we certainly can come up with a pre-hospital diagnosis or field assessment of what's going on. And so it's often the same as the chief complaint. For other examples, syncopal episode or hypoglycemia or, possible fracture to the right upper extremity, those types of things. And so it should be very short, very few words go in the A assessment. And then P, plan of action. What are you going to do? What did you do? What do you do for your patient? And so write it down. Documentation is so important. And by the way, when I first started out doing my documentation and I took this method of SOAP, I wrote in my narrative, I wrote out S and then all the stuff for subjective. And then I put an O and all the stuff for objective and then A and P. And I did it that way for the longest time, and that might help you. All of your treatments should go here under P. And again, try not to repeat what may be documented elsewhere. Now, in other types of strategies, we were talking about a system documentation. Now let's talk about some other strategies in your writing your report. Remember your audience. Remember who else is going to be reading this, such as billing, they may be non-medical people, quality improvement, QI, lawyers, insurance investigators, supervisors, etc. Strive for a meticulous report. I mean, it's just really important that your report look good, that you have correct spelling, that you have legible handwriting. If you're still writing reports, again, in this day and age, we're doing a lot of electronic reports, notebooks, pads, whatever you might be using where you work. Proper spelling is really important. One of the great things I love about the electronic reporting is spell check, okay? But I will tell you that spell check doesn't catch your grammatical errors, and I'll talk about that in a minute, your grammatical errors. Use only approved medical abbreviations in your reports. Also realize that documentation is going to be a memory tool for you. If you get called to court on a call, it may be years after the fact. It may be years later. And if you're like me, you ran a lot of calls in between those calls every year, sometimes every day. And so good documentation is important because you're going to need to look at that to remember years later down the road. Also realize Medicare may ask for more information months after the call. Reimbursement is important. We as medics tend to not want to think about the dollar issue, but we wouldn't have a job if our company doesn't succeed and exist and get payment. And so Medicare needs good documentation, and sometimes they'll ask for it later. Now, this is my favorite strategy or my favorite item in being a good documenter, and that is to create a detailed picture. If you can create for me a picture for someone who wasn't there, what was going on, if I could read your report and say, I know exactly what was going on, I can picture this, then you've done a good job. So describe the scene and events the best you can and in the best detail you can in the space provided. I'm not asking you to write a novel. I'm not even asking you to write a short essay, but I'm asking you to do good documentation. Explain the patient's condition, what was going on at the time, the past medical history if it's available and if it's pertinent, and detail your findings. What did you find? What were your findings? Put them down. Of course, document all treatment rendered, because you need to remember this next saying. If you don't write it down, if you don't document it, you did not do it. That can get you in a lot of trouble later on if your call gets, for some reason, you have to go to court about it. And standard protocol is, you do something, you do some certain skill, and you know you did it, and everybody else knows you did it, but you didn't write it down. Sorry, but you didn't do it, and that's going to cause problems. So again, remember, create a detailed picture, report any changes in the patient's condition, whether they be improvements or worsening, explain any extenuating circumstances such as delay in getting to the patient, a delay in getting to the hospital, long extrication times, those types of things. Note any events that occurred en route, such as patient began seizing en route, patient began vomiting en route, those types of things. Then again, note any changes in the patient's status or condition. Detail your actions and your patient's condition. Make sure to write a detailed statement of what was going on with your patient. Document the times of the call, times you started an IV, times you may have defibrillated, times you may have placed a tourniquet or a splint, extrication times, those types of things. And so not only your dispatch times, but times of treatment, the time you gave that baby aspirin, that nitro, that epinephrine, whatever you may have given, the time that you saw changes in the patient's status, and any special events. For example, time down, if you know it, time without oxygen, extrication times, etc. And documentation involve other personnel, involve your peers, your co-workers, your partner. On a call on documentation, all crew members are responsible. However, only one person should actually do the writing. But all members should be responsible, should agree, should discuss the run and what happened, should discuss your documentation after the fact. Don't be so proud that you say, oh, I was the lead medic and I wrote this up and I don't care what you say. Don't be that way. That's not the way to improve. Then you should also make sure everyone agrees. And by the way, if you are not the lead medic and you do not do the reporting and you disagree, then you have the right to put that in writing, either on that run report or create your own. For your protection, I would probably create another one of your own. Proofread your documentation. This is so vitally important. I'm in this habit, and if I don't, I make mistakes that make me look goofy, silly, and we don't want to do that. We want to look good. We want to look professional. As I said at the beginning, documentation is going to make you look professional or unprofessional. It's up to you. So proofread your documentation. Ensure it's accurate. Look for mistakes. Ask other crew members to read it, looking for mistakes. Read it aloud. One of the reasons you want to read it aloud is your mind, as you read things silently to yourself, your mind can put in the words that you meant to say, but you may not have wrote them down. And so by reading it aloud, you can then hear what you actually wrote. It may not jive with what you meant to say. So look for mistakes, make sure it's accurate, look and ask other crew members to read it. Don't be so proud and be willing to accept constructive criticism. All right, there's also a certain way to correct errors in a legal document, and you remember that it is a legal document. And so we don't want to erase or obliterate the error. We simply want to draw one line through the error, write error, initial it, date it, then you can put the correct word next to it or in it. Or if it's after the fact, then actually you should do an addendum. And I'm not going to spend any time in doing an addendum. You can learn how to do an addendum where you work, which is also important to understand the protocols and policies and procedures where you do work. What do they want? How do they want certain documentations? And it's very important. And also it's important for you to remember that refusals are the number one cause of lawsuits in EMS. The number one cause for you to possibly get sued is due to refusal. And so if you don't have good documentation, you can be in trouble. 50 to 90% of all lawsuits in EMS are over refusals. And so accurate documentation is just vitally important. Non-billable runs are also important for your protection. What I mean by non-billable runs, we often think of these as not important, but they are. Such things as false calls, mutual aid calls, and canceled calls. You should document that these occurred, because what if someone was in need of help, but someone come back to you and said, well, they canceled us, okay? Who canceled you? You better find out. You better write down who canceled you. Police officer on scene. Well, I don't know many police officers who are on a scene that cancel us without checking somebody out. If they did that, then they're going to be responsible. If you never made it to the scene, it's important for you to document that, because later, what if someone is hurt or even dies because you didn't come all the way to the scene and they want to sue you? Well, now you have the documentation that, hey, someone canceled us, and who. The way to improve your skills of documentation is to review past reports. Not only yours, but reports of others. It helps you to improve your reports. It also helps you to be consistent. You can learn from your mistakes and others. I had a big habit of, when I first started as a medic, I would read lots of other run reports. And of course, this was the days before electronic reports. Yes, I'm dating myself, I understand, back in the horse and buggy days. But I would read others' run reports. And I found one or two people that did really good jobs. And so I would take parts of what they did and incorporated into mine. And so it was really, really helpful. And so again, just to reiterate, documentation is a skill just like starting an IV is a skill. So you need to develop good writing skills. If for your paramedic degree you're not doing the degree or you've never taken English composition, I highly recommend you take a composition course. Good writing skills are important. Read up on it. No, I know I wasn't very good at English, but I took those courses and I read on how to improve in writing skills, and it's just really, really important because, as I said earlier, it's going to either make you look good or it's going to make you look bad. We don't want to look bad, do we? I don't know if anyone wants to look bad. You small pocket spellers, when I first created this presentation, smartphones were not out. Again, dating myself a little bit, but although it wasn't that long ago. But now smartphones, you can get these apps with spellers. You've got Google on your smartphones, or they've even got these small electronic spellers that are the size of a deck of cards. Place it in your pocket, or even the little printed books. They'll help you. I used to use them. Find someone that has good documentation skills and learn from them. As I mentioned earlier, that was one thing I did. And then accept constructive criticism. Be willing to realize that they're there to help you. If it is constructive criticism, now I'm not talking about the criticism. They just want to cut you down. They want to hurt you. But do accept constructive criticism. It's meant to help you improve. So in conclusion, again, documentation reflects our professionalism. And poor documentation is going to make us look unprofessional. It's going to make us look bad. So you need to have good documentation skills. And realize this, people do not see you in action, but they do read your reports afterwards. And so it's really, really important. You say, well, I'm a good medic. I can start IVs that other people couldn't. I can intubate other people couldn't. But okay. What about your documentation skills? You had to work to get those skills good, didn't you? And so it's important to work on documentation skills because people don't like to hear this. I know this from a fact. I'm talking to my students and peers and coworkers. They don't like to think about documentation as a skill, but it is. And you are only as good as your documentation. So make it good. Improve it. Work on it. Always strive
to be the best that you can be. And that includes working on and improving documentation.